Welcome, everybody. It's with much excitement that I introduce our current Roybal Center speaker. This is the Columbia Roybal Center for Fearless Behavior Change, and I believe Mary will be our last speaker until after the summer. So thank you very much, Mary, for coming to present to us. So Dr. Princip, I should say, is the head of research at the Department of Consultation Liaison, Psychiatry and Psychosomatic Medicine at the University Hospital Zurich in Switzerland. For those of us in North America, in Switzerland, they do have a little bit different of a specialty in terms of psychosomatic medicine, which is sort of a combination of psychiatry and internal medicine a little bit together in a very distinct way. And they sometimes have very separate units. I don't know, Marie, if she can say if that is true in Zurich, but specifically for patients that have psychosomatic conditions in a way that's very different than us, and I think something for us to learn from. But today specifically, she's going to be speaking to us about a topic that many of us are familiar with. It's the acute coronary syndrome induced post-traumatic stress symptoms, features, consequences, and treatment options. And Mary, I'm not sure how familiar with our work, but we've been, for the last 5+ years, have been working on enrolling patients that have had suspected acute coronary syndromes and evaluating them for PTSD. And now through our Roybal Center, we're really interested in thinking about how to develop interventions to help them. And we're really interested in learning more about your work.
Yeah, thank you so much. I warmly welcome you all to my presentation about ACS-induced PTSD symptoms. I'm really happy to have this opportunity to give you insights in our research work, and a special thank and a warm welcome to Roland von Känel, head of our clinic and my mentor and guide since 2013. It's such a pleasure working with you. Thank you so much. So, as you know, maybe we have a lot of high mountains in Switzerland, and sometimes it feels like when we work in this research field, it's like climbing this mountain. So for the next hour, we will climb this mountain together, and I will show you something about ACS, PTSD, ACS-induced PTSD. I will show you 2 of our studies. One is still going on, and for the last section, we will speak about treatment options. So the question is, what is ACS? I think we are all familiar with it. It's defined as an unstable angina or non-STEMI segment elevation or segment elevation. And it's not only the leading cause of the Western society with almost 900,000 yearly deaths, it's also have significant economic consequences. So from a demographic perspective, we have nowadays a better healthcare system, which leads to an increase of the survival rate, which is very good. And on the other hand, we have the increase in the older population, meaning more cardiovascular diseases. So the question is, why can an ACS be traumatizing? So I brought a case study, Mr. B. He is 54 years old, a hardworking man, married, had a high socioeconomic status. He's a sales representative, non-smoker with hypertension and obesity, and he described his heart attack as follows. I drove home after a long day at work. I loosened my tie, which was tied around my neck, and tried to take a deep breath. Unsuccessful. The rain pelts the windshield, and I has a hard time concentrating on the road. I tried to calm down and turned on the car radio. And then I suddenly felt sick and felt like a vice is stuck between my ribs. My heart was racing and beads of sweat formed on my forehead. As if I'm in a trance, I pulled into the nearest parking lot, grabbed my mobile phone, watched myself dial the number for the emergency room, opened the door, and laid down on the wet asphalt, grasping for air. So it seems completely understandable and reasonable that with this sudden incoming devastating pain and a real life-threatening situation, patients such as Mr. B have feelings of helplessness, vital threat, loss of control, or fear of dying. And often, luckily, these symptoms will disappear, but what happens when this symptom still occurs? And we speak maybe from a diagnosis of PTSD. So PTSD is included in the category of trauma and stressor-related disorders. A diagnosis of PTSD requires exposure to an upsetting traumatic event. However, the exposure could be indirect rather than first-hand. So, for example, parents of children with critical congenital heart defects are also at high risk for post-traumatic stress disorder. And symptoms of PTSD fall into the following 4 categories. So the first one is intrusions, the re-experiencing of the event. So we are thinking of Mr. B. He keeps recalling how the heart attack came out of the blue while he was trying, and how he lay on the floor thinking he was going to die. And the next one is criterion C, avoidance of trauma-relevant memories and activities, places, and so on. So Mr. B avoids driving a car, and he takes the medication only irregularly because it reminds him being a heart patient. And the criterion D, negative alterations in cognition and mood, means Mr. B felt cut off from his family and had persistent fear. Criterion E, alterations in arousal and reactivity, means he had trouble to fall asleep, for example, was irritable and having problems concentrating. So for a person to be diagnosed with PTSD, symptoms must last for more than a month and must cause significant distress or problems in the individual's daily functioning. Many individuals develop symptoms within 3 months of the trauma, but sometimes symptoms may appear later and often persist for months and sometimes years. So altogether, we have a cardiac event that occurs very frequently, and on the other hand, we have a disorder that has a huge impact on the entire body, including cardiovascular functioning, hormone system balance, and immune functioning. So the question now is, what are the typical features of an ACS-induced PTSD? And when we look at the prevalences, we find moderate fear and distress in over 52% of patients following an ACS, and 22% of patients report intense distress and fear of dying, and 4 to 16% develop clinically relevant symptoms of PTSD. So these prevalent rates for cardiac arrest or ICD implantation, heart surgery, or heart transplantation are even higher and up to 40%. So Maley et al. Could identify 3 PTSS trajectories over 1 year. The one group that is resilient, the one group that is chronic and worsening, and the one group that has acute symptoms and then recovers. So when we compare these rates with lifetime prevalences in the general population ranging from below 1% in the European countries where I live, up to an average of 8% in countries such as the USA, we have a high amount of patients qualifying with PTSD in the ACS population. And the question is now, what are the predictors of ACS-induced PTSD? What do we know? In these different subcategories, we find, for example, in the socio-demographic factors, we find a young age or female gender. And we have event-based factors, for example, a hectic environment, crowding, or long waiting times. And for the history factor, we have earlier hospitalization, PTSD in the past, critical life events, earlier cardiac events. And from a personality perspective, we saw that type D personalities or alexithymia as well as neuroticism are personality factors that increase the risk to develop ACS-induced PTSD. Comorbidities such as depression, anxiety, or somatic burden are also predictors. And last but not least, illness perception, particularly beliefs regarding harmful consequences after acute MI, were independently associated with PTSD symptoms. Interestingly, no objective cardiac parameters, for example, troponin levels or CKMB levels, were not found for PTSD. So it seems that the subjective perspective of the illness is much more important when it comes to PTSD. So are they protective factors of ACS-induced PTSD? These are very unspecific protective factors. I will show you. Social support, of course, qualitative functional social support is meaning being supported in ways of guidance and assistance from others and reassurance of one's worth. Resilience factors, for example, optimism, purpose of life, or mental flexibility, and also self-esteem seems to be protective. And very interesting, a repressive coping style, the unconscious avoidance of negative stimuli in the acute phase after the trauma. And maybe this is the reason why debriefing is not very good when we do debriefing in the acute phase following an acute cardiac event. So now let's have a look. What are the specifics of ACS-induced PTSD? Edmondson described this in the enduring somatic threat model. I think it's really great because it brings it to the point. The acute medical event has a somatic cause. It's in our body when the event took place. The external cause is in the external traumatic events. So when it's in our body, it means the threat is enduring. It's not temporary. So both of them will develop PTSD. Both of them will feel fear of dying. But intrusions of PTSD in ACS patients are often future-oriented and leads to flash-forward intrusions. So that means Mr. B, for example, were afraid falling asleep because he had intrusive thoughts to suffocate. And the second one is avoidance behavior is very difficult. So it's almost impossible because body signals as constant reminders of the infarction are there. We feel our heart every second. And avoidance is dangerous because of the necessary therapies and thus can increase feelings of guilt. So this all with the hyperarousal, which is associated with internal cues, is very different because the hyperarousal symptoms are so difficult to distinguish from symptoms of a recurrent life-threatening cardiac event. So meaning we can't avoid intrusions are often future-oriented and ongoing threat is going on. And this all leads to an increased risk for recurrent cardiac event. It leads to non-adherence, sleeping disorder, increased inflammation, increased blood pressure. So at the end, Mr. B ended up in an anxiety cycle through sympathetic activity contributing to unfavorable cardiac prognosis. So what happens when we do not treat ACS-induced PTSD? What are the consequences? We have a meta-analytic evidence of 96 studies suggests that depressive and anxiety symptoms improve for 1 year after heart surgery, whereas PTSD symptoms even worsen. And over 2/3 of patients with ACS-induced PTSD show PTSD symptoms 2 years later, and they seem to be persistent for at least 3 years after an acute cardiac event. So treatment is very necessary to reduce chronic conditions. Not only PTSD persists in most of the cases, PTSD is somewhat toxic in different ways. So untreated, we find lower levels of quality in life, more recurrent events, and increased mortality and hospitalization, pathophysiological changes such as lower HRV, or higher inflammatory processes, higher rates of non-adherence and a non-favorable health behavior, for example, more alcohol consumption, smoking, and lower sports activity. So it's clear intervention is needed. The question is, when and how can we intervene? And here we have a very nice systematic review. Shall we intervene early after ACS? And we can, because we saw that evidence shows that education, cognitive behavior therapy, meaning making, pharmacological, palliative care might work for medically related PTSD. And It works when individuals show early symptoms of traumatic stress, when they are highly distressed, when the intervention is trauma-focused, and when psychological debriefing of traumatized patients is avoided. However, it was not clear if this all works out for ACS patients, so we gave it a try, and maybe you know this study already, and we were running the MI Sprint trial. Roland von Känel was the principal investigator. It was a single-center randomized controlled trial with 2 active intervention arms, and patients were randomly allocated to a single 45-minute counseling session targeting either specific MI-triggered traumatic reactions or the general role of psychosocial stress in coronary heart disease, so the controlled intervention. The project was for 3 years in the University Hospital in Bern, and we got some financial additional funding by the Swiss National Science Foundation. So the overachieving aim of the MI Sprint trial was to reduce the development of post-traumatic stress in patients with acute MI through a single session, 45 minutes, trauma-focused in psychological counseling in the hospital. So we had 2 active intervention arms, which were equal in the contact time with the counselor. We have the same study assistance within 48 hours after the acute MI by the bedside in the coronary care unit. And after the counselor session, they handed out a booklet they could read within the whole time. So the primary hypothesis was that the intervention group will report 20% lower post-traumatic stress levels measured with the CAPS interview, the gold standard, to qualify for PTSD than the control group at 3 months follow-up. And this group difference will persist at the 12-month follow-up. Secondary, we wanted to compare if the control group will show better psychosocial functioning and a more favorable profile of cardiometabolic biomarkers of atrial thrombotic risk at the 3 months follow-up, and this group difference will persist at the 12 months follow-up. We included patients which were 18 years or older, had a STEMI or non-STEMI, had reached stable circulatory condition, and had a high distress. A high level of distress means it was defined by a minimum score of 5 for pain and of 5 for fear of dying and or helplessness. Exclusion criteria were emergency coronary artery bypass graft surgery, comorbid serious disease likely to cause death within 1 year, current severe depression not fully oriented to the situation and place, cognitive impairment, insufficient knowledge of German language in reading and understanding, suicidal ideation, participating in any other randomized controlled trial. And the 45-minute counseling session covered the following topics, always related to MI as the trauma. So in the Verum group, we had topics like what is a trauma? Why can acute MI be understood as traumatic experience? What is PTSD? How to cope with the trauma, tackling avoidance, coping with safety behaviors, and so on. So the core components were normalization, education, information, resource activation, and cognitive restructuring. In the active control group, we covered topics such as what is psychosocial stress and when can it become dangerous, which types of psychosocial stress are known to potentially have an influence on CHD and cardiac prognosis, why do not all people react the same way to psychosocial stress, and so on. So it was a similar approach, but strict avoidance of trauma-related terminology and content. The time course of the MI Sprint trial you can see here. So after the myocardial infarction, within 48 hours, we handed out the psychometrics, and then they were either allocated to the intervention or the control group. We had the counseling session for 45 minutes, gave them the booklet at the end of the session, and collected blood at 6 a.m. in the next morning. After 3 and 12 months, we invited them again. We took blood, we made the CAPS interview, and they filled out questionnaires again. So, as you can see here, the bubble burst. Unfortunately, we couldn't show that our trauma-focused intervention group showed better PTSD values compared to the control group. So it was a little bit sad, but let's have a deeper look. So our baseline characteristics of the 190 study participants was very similar, except for the fear of dying. So the fear of dying was higher in the trauma-focused counseling group. We couldn't show that there was differences in the primary outcome between the intervention arms. So the CAPS total was not different, but we could show, unfortunately, that the self-rated PTSD scale was even lower in the control group, in the stress counseling group. So when we compare it with the incidence of a clinician-rated diagnosis of ACS-induced PTSD and levels of self-rated PTSS at 3 months in different studies, we could show that only one of the 190 patients we included in the study qualified for a PTSD diagnosis after 3 months, and this finding was stable over 12 months. So this was at least a very good finding. So the question is, what did we learn from the MI Sprint study? I think we learned a lot. High distress ACS patients did not benefit from a 45-minute single session trauma-focused counseling compared to a stress counseling session. The trauma-focused counseling group had even higher self-rated PTSS featuring versus the stress counseling group. A single counseling session might prevent ACS-induced PTSS, although the content of such interventions need to be explored in further studies. And trauma-focused early preventive treatments should be avoided, particularly so in patients with high clinical burden. But as I said before, only 1 out of 190 highly distressed patients qualified for a PTSD diagnosis. So it remains unclear which non-specific factors, maybe it was a placebo effect that we were sitting at the bedside, might play an important role in the incidence of PTSD. So, however, we found some very interesting secondary results. I can't go through every one, but I will pick out for you some very interesting ones. For example, positive affect is associated with favorable lipid profiles, or very interesting, benzodiazepine exposure increased the relative risk for PTSD levels almost 4-fold. So we have to avoid to give benzos in the acute phase when highly distressed patients are there. Or low serum cortisol at admission associated with greater overall PTSD severity 3 and 12 months after MI, patients with greater social support or longer participation in cardiac rehab had fewer PTSD symptoms in the trauma-focused group compared with the control group, and the number of psychotherapy sessions did not moderate intervention, or perception of hectic environment, as earlier studies could show, is associated with peritraumatic stress. So we published 22 studies and we still analyze our data. So it's really great what we found out. So question is, treatment when PTSD is established, is it better when PTSD is there? What might help for ACS-induced PTSD patients? We have very rare studies, but what we know is treatment of PTSD in general means that EMDR, so eye movement desensitization and reprocessing, and trauma-focused behavior therapy, TFBT, are the most effective therapies to reduce PTSD or PTSS. But EMDR might have advantages over TFBT because it requires 40% fewer treatment hours, is cost-effective and lower burden. So more effective means that arousal and intrusions are better in the EMDR technique than in the TFBT group. From a pharmacotherapy perspective, in the acute phase, it's better to avoid benzodiazepine, beta blocker, cortisol and opioid should be fine, and SSRI could give only in combination with trauma-focused therapy. So this is in general. So is trauma-focused therapy for ACS patients safe? And we can answer this with a yes. So Shemesh et al. Could show in 60 patients with PTSD resulting from different cardiovascular diseases that 3 to 5 sessions with either imaginal exposure therapy versus 1 to 3 sessions education, the control group, resulted in no higher blood pressure, no higher heart rate during EIT, no more deaths, hospitalizations, recurrent MI, invasive procedures, and showed significant improvement of PTSD symptoms in the subgroup of patients with acute unscheduled CVD events. So is maybe EMDR for the treatment of established ACS-induced PTSD a good way? They could show Arabia et al. In 42 patients after cardiac surgery that EMDR was associated with a significantly high reduction of PTSS, anxiety, and depressive symptoms. It's better than prolonged imaginary exposure therapy for 4 weeks, but it was only a pilot study. And another study could show in 20 patients with ICD shock-induced PTSS, EMDR resulted in a reduction of PTSS, anxiety, and depressive symptoms at 1 year. It's not a control group. And EMDR was accepted by patients, emotional arousal was tolerable, and no cardiac complications occurred during EMDR confrontation. So it seems reasonable to have a closer look to eye movement desensitization and reprocessing. So EMDR was discovered by Francine Shapiro in 1987. It's an integrative psychotherapy approach. It has a standardized procedure and 8 treatment phases, and over 30 RCTs have proven the effectiveness of EMDR. The central elements are focusing on the traumatic event and bilateral stimulation with tapping, with eye movement, and so on. So the EMDR protocol includes the assessment of body sensations and future-oriented intrusions, which is followed by reprocessing. So the bilateral eye movement during reprocessing seem to have a de-arousing effects and may interrupt the positive feedback loop between cardiovascular sensations and anxiety-induced arousal as envisioned by the enduring somatic threat model. So maybe EMDR might be more suitable in cardiac PTSD compared to treatment protocols, which motivate patients to keep focusing on the traumatic event, where higher emotional involvement seems to be related to a better outcome. But mind the gap, no RCT with EMDR treatment for ACS-induced patients were there. So we were full of enthusiasm and we tried it again, or let's say we try it again because this trial is still running. We have a trial in Switzerland called EMDR treatment in PTSD following ACS. The principal investigator is Christoph Müller-Pfeiffer and the co-investigator is Roland von Känel. The aim of the study is a randomized controlled trial to investigate the efficacy of eye movement desensitization and reprocessing therapy in treating post-traumatic stress disorder following ACS against a passive waitlist control group. So we decided not to have an active intervention group. So study's design is it's a randomized controlled trial with 2 arms, PTSD patients receiving either EMDR therapy on traumatic event or the patients are in the waitlist control group. All patients qualify for PTSD diagnosis caused by the ACS that is verified with a CAPS interview from an experienced psychotherapist. We want to include 25 participants in the intervention group and 25 participants in the passive waitlist control group. The project duration is 40.5 years. We started in 2020, and for each participant, it means 36 weeks or 9 months. It's a monocentric study at the Department of Consultation and Liaison Psychiatry and Psychosomatic Medicine in the University Hospital in Zurich, and patients get reimbursed with $150 US. So the primary hypothesis here is that post-traumatic stress levels as assessed by the CAPS interview will be lower in the intervention group than in the control group. and secondary, we want to show if the reduced psychophysiological responses to sudden noise bursts at 3 and 6 months in the control group and versus the intervention group. Compared to the control group, the intervention group will show a lower risk of cardiovascular disease evidenced by a more favorable level of inflammation markers, metabolic factors, and so on. So we include patients that are 18 years old or older, men or women, have an ACS and a diagnosis of PTSD caused by the cardiac event. We exclude patients with current psychotic disorder, bipolar disorder, substance abuse, as measured with the mini international neuropsychiatric interview, with acute suicidal ideation as assessed with the mini, have non-selective beta blockers, ongoing trauma-related treatment outside the trial during the study period, have visionary problems, insufficient knowledge of the German language, or expected inability or willingness to follow the study protocol. So as you can see here, we all recruit our patients in the university hospital in Zurich, and we go to the bedside and hand out a flyer and show them that we have a study here and that they will be contacted when they are at home, back at home, and we will send a letter 2 weeks after hospital discharge. And after 4 weeks, we will make a phone screening, a telephone screening for 20 minutes, where we'll use the PCL5, the checklist for post-traumatic stress disorder. And if they have a cutoff from 28 or higher, we will invite them to the CAPS interview. We will do the mini, and the second assessment will take place at another date because it can interfere with the loud tone testing. So we will have the second assessment with the blood collection, the loud tone procedure, and the psychometrics. And then they will randomly allocate it to either the EMDR therapy with 8 sessions or 60 minutes or the waitlist control group. And the follow-up after 12 and 36 weeks will take place also with the CAPS interview, the blood collection, the loud tone testing, and the psychometrics. So the intervention group has a total of 8 sessions, as I mentioned before, of 60 minutes with an EMDR certified psychotherapist according to the 8 phases of the EMDR standard protocol, so history taking, treatment planning, preparation, assessment, desensitization, installation, body scan, closure, and re-evaluation. And the standard protocol was adapted to ACS events. So we ask for hospital experiences, surgeries, and experiences with practitioner, etc. We focus on future-oriented intrusions, and this is possible when you work with EMDR in terms of the ongoing threat model, and the protocol was adapted in cooperation with Dr. Michael Hase. So we have a lot of biomarkers and psychometrics, for example, stress hormones or metabolic factors. We have as well noise-related psychophysiological responses, the skin conductance, the HRV, we have psychiatric symptoms, disorders, personality traits, cardiac-related variables, and for example, the perceived threat during cardiac event, or social support, or quality of life, and so on. So we have a lot too. And after 1.5 years, we could include only 9 patients. We could recruit 2 female and 7 male. We had 4 patients had undergone EMDR therapy so far. 1 patient refused to continue after 2 sessions. And we have now an amendment which is pending because we have a lot of problems with the recruitment, and we thought maybe it's better to include all cardiac events instead of ACS. So maybe this will help. So unfortunately, I can't show you any results yet, but yes, it is what it is. Sometimes the main focus is when we have an ACS, we have to try to find the balance between overwhelming and regression or trivialization. And this means a successful adaptation. And for this purpose, we thought what could be good treatment options. So possible treatment options means most of these recommendations are based on experience and need to be tested in cardiac diseases. But we thought maybe in the acute phase, with all our experience and the MI Spring trial, we should provide safety and control first. We should consider physical needs. We should avoid benzodiazepine. We should create a calm and supportive environment. Supportive talk can be offered. We should install social support, and we should focus on reorientation in the presence and screen for distress, and avoid debriefing and avoid trauma-focused content. So the core issue is there, normalization. In the adaptation phase, we maybe can educate about the illness and emotional reactions. We can show stabilization techniques. We can activate resources to cope with the illness. We can include relatives because they are very important when it comes to the illness perception. We can create a plan of action. We can structure daily activities. We can prepare a plan for action for emergency. We can address anxiety sensitivity. We can promote relaxation techniques and increase vagal activity, and we can motivate for cardiac rehabilitation. So the core components there are reorientation, stabilization, and psychoeducation. And when it comes to the treatment phase, we should maybe reprocess dysfunctional beliefs. We should desensitize negative emotional affection, reduce hyperarousal, this inner tension, this pressure, this pain. We should change negative beliefs in form of I'm helpless, I can handle it. We should address future-oriented intuitions and differentiate between real danger and body sensations, because it's very typical for heart patients. We should integrate heart disease in life and re-evaluate health-related risk factors and motivate for long-term physical group sessions. And eventually, we should consider SSRE for long-term. So the main dimension here is reprocessing traumatic memory and future-oriented intuitions and new orientation. So the questions now are very varied. So how can we promote adaptive processing of traumatic cardiac events, or how can we focus on protective factors? Maybe it's another approach. Or how can we treat specific features of ACS-induced PTSD, such as flash-forward intrusions? Maybe it will work out with EMDR, we don't know. Maybe how can we test specific mechanisms that underlie the success of PTSD interventions, for example, fear habituation, improved self-efficacy, or how can we develop risk profiles, or considering relatives with PTSD and children with heart transplantation, with cardiac arrest, how can we promote personalized care? How can we determine which are the precise characteristics of symptomatic patients? And how can we measure the specific features of ACS-induced PTSD? And last but not least, how can we find out which are the moderators and predictors of intervention effects? These are all questions we are going to explore. So, but at the end, I hope you had a very good climbing up with me on the mountain. Maybe we didn't reach the peak now, but we have a spectacular view. We have a lot we've learned, and even a journey of 1,000 miles begins with the first step. So thank you very much for your attention. Thank you to Roland, thanks to Christoph, and my lovely colleagues, Rebecca, Jürgen, Ulrich, Jean-Paul, Hans-Jörg, Katharina, Claudia, Michael, Hannes, Jori, Julian, AJ, Hans-Peter, Rahel, Lisa, Kevin, Sintu Jan, and Noel. Thank you very much. Science rocks.